paper and the new data from cortical and subcortical intraoperative motor mapping. I'm Prajwal Ghimire, presenting from King's College London, King's College Hospital in London, UK. This is my disclosure slide. I do not have anything to disclose and no conflict of interest in any of the stuff utilized in the mapping. I'll be discussing in detail about the study we performed with cortical mapping and subcortical mapping, thus proposing the new maps, the supplemental map for the Penfield Homunculus, as well as the subcortical corticospinal tract maps. I would like to introduce by mentioning the giant in the picture, Mr. Penfield there itself, who initially, with his seminal paper in 1937, was able to give us in detail mapping of human brain on different areas of the motor cortex. He performed these mapping awake in all patients, over 126 patients to be specific, in different parts of the human body onto the motor cortex, legs being medially and followed by arms and the face going laterally across the motor cortex. And thus the homunculus was born at that time. Coming from 1937 till now in 2021, there has been a lot of advancements in different types of monitoring techniques, and thus we planned to study this different monitoring of cortical as well as subcortical corticospinal tract to try and see if we can map further in detail. So we did a single retrospective study from January 2015 to January 2020 with 180 patients, a combination of awake as well as sleep craniotomies for eloquent brain lesions, which included a variety of lesions from gliomas to vascular malformations, with intraoperative cortical and subcortical mapping. Here we utilize the motor threshold to identify the distance from the corticospinal tract with a rough measurement of 1 milliamps equal to 1 millimeters as published in the literature. Preoperatively, all the patients underwent a neuro-oncology multidisciplinary discussion followed by MRI tumor protocol, and also addition to that, other imaging like functional MRI, diffusion tensor imaging with tractography, both probabilistic and deterministic tractography, and transcranial magnetic stimulation in majority of the patients. Intraoperatively, we utilize cortical and subcortical motor mapping with stimulations as well as continuous recordings of the MEPs or the motor evoked potentials. We also utilized most of the patients intraoperative ultrasound to counteract on the brain shift. Postoperatively, these patients underwent T1 post-gadolinium MRI to study the extent of resection. The images on the slides demonstrate the functional MRI on the top, followed by the 3D reconstruction of the points taken in the transcranial magnetic stimulation, probabilistic as well as deterministic tractography configurations, and ultrasound, followed by the intraoperative MEP recordings. Coming to cortical mapping, in this study we utilized recording of the cortical motor evoked potential with direct electrical monopolar stimulations of primary motor cortex with parameters of trend of 5 pulses, positive pulse form interstimuli interval of 4 milliseconds using anodal pole. Further to that, we recorded continuous MEPs over the motor cortex using the 4-strip contact strip electrodes to record at a motor threshold. Different muscles were utilized to record these findings on the face, upper limbs, as well as the lower limbs, according to the published literature. In our patient demographics, we had 180 patients of average age of mean age of 50. Majority of the patients were right-sided lesion, and 46% had left-sided lesions, majority being males, and 58% and 80% of the lesions were gliomas. 23% were low-grade, and 57% were high-grade lesions. Other lesions were vascular malformations, metastases, and meningiomas. On the cortical motor mapping, so we utilized the monopolar stimulation to identify different regions of the brain. So here you can see on the picture images on the A, you can see 1, 2, and 3 being the hand and the forearm area, 4 and 5 medially being the foot and leg area. Similarly, in picture B, we mapped in detail the hand knob in the motor cortex lateral to the hand, lateral to the leg area. The 6, 7, 8, 9, 10, 11, 12, 13 demonstrate the hand knob. The 1, 2, and 5 demonstrate postcentral gyrus. On the C image, we were able to map on the cortical surface for the first time in the literature the intercostal muscles in the trunk area of the homunculus, 5 being the foot area, lateral to that the intercostal, and followed by the upper limbs and the hand area further down. On the D image, I can here further demonstrate the similar representation, here mapping more in detail of the face area in 6 and 7, 1, 2 being the arm and forearm, 3, 4, 5 being the hand area. During the cortical mapping, we utilize the suction probe monopolar stimulation as well as the monopolar electrodes itself to map these areas. And we were able to demonstrate a reliable motor threshold on the surface for the leg, generally of 12 milliamps on average, for intercostal muscles at 12 milliamps in the trunk area, and arm of 10 milliamps, hand 6, and face 10 milliamps. This is the case series that we were able to reproduce the mapping of the intercostal muscles, which has not been previously studied, and we have demonstrated that this in our paper published in 2021, showing multiple patients with different pathology from primary to metastatic lesions demonstrating cortical as well as subcortical mapping of the intercostal muscles. So thus we proposed a supplemental map of the intercostal muscles, adding to the previous map demonstrated by Penfield, thus producing this new map. Further to that, on the subcortical stimulation, we utilized similar techniques or parameters with monopolar stimulation, and thus we and also did some literature review that demonstrated very minimal demonstration of trunk, but mostly leg, arm, and hand area. But we proposed and we demonstrated this in the case report initially, followed by the case series. On the subcortical mapping, so this is a detailed subcortical neurophysiological tree, where we're able to map all the areas, leg, arm, hand, face, as well as the intercostal muscles, even in the subcortical area from 1 to 15 numbers in the picture demonstrated. And with the motor thresholds being different for leg, intercostal muscles 4 milliamps, and a bit higher for the arm, hand, and face in the subcortical region. And thus we were able to map those points into a map of the subcortical homunculus, and demonstrating the hand area in the middle with the intercostals between the leg and the hand, and the trunk area on the surface, and then subcortically going down further. The configuration changed at the depth, where the leg area became more lateral and the face area became more medial, going down to the internal capsule and to the brainstem. And thus we propose this map that will be very useful for the future studies, as well as resection of the tumors and to reduce the risk, and for ultimately for good patient outcome and quality of life. And thus we demonstrated this findings on our paper published recently in Brain Structure and Function in 2021. And the future directions for these mapping would be to produce a probabilistic atlas and maps with the large-scale prospective studies with normalization of these points to demonstrate these further in detail. And I would like to thank my team for helping me out with this paper and this presentation. And I will accept any further questions from the team.